Suicide plan, a proposed method of carrying out a design that will lead to potentially deadly or self-injurious outcome. And suicidal intent, expectation and desire for a self-destructive act to end death. Suicide attempt, self-injurious behavior, with non-fatal outcome accompanied by explicit or implicit evidence that the person did intend to die. And suicide, self-inflicted death with explicit or implicit evidence that the person intended to die. So those are our basic definitions. Also, very importantly today, these definitions need to be included in our discussions about suicidality. Validation. We hopefully are all doing this as mental health providers, and it is a hugely important component of working with those who are suicidal. Emotional validation is a process which involves acknowledging and accepting another individual's inner emotional experience without necessarily agreeing with it or justifying it, right? That's important because we're talking about suicide. It is a process that fosters empathy, strengthens relationships, and helps resolve conflicts. Hugely important in the topic that we're discussing. Emotional invalidation, on the other side, occurs when an individual's emotional experience is rejected, ignored, or judged, often through words or actions indicating that their emotions are unwarranted or irrational for the situation. So in reading that definition of invalidation, I hope that we can start to see how that's really easy to do when we are responding to a suicidal client. So I'm going to give you guys some tools to work more in the validation category and still help people to be safe without invalidating what they're going through. And then compassion, because we're working on compassionate response, deep awareness of the suffering of another coupled with the wish to relieve it. Okay, impact of suicide. So if you all could, I want for everyone to open up the chat box and click on the little emoji that's in there and search for candle, CANDLE. So it should bring up a little candle icon, okay? And I want you to just hold it up on your screen. And I am going to read a few statements, okay? And I want you to send your candle into the message box if any of these statements are true for you. I have lost someone to suicide. I have a friend or family member struggling with suicidality. I work with or have worked with clients struggling. I have worked with or am working with clients struggling with suicidality. Or I want to help those who are struggling. It's pretty difficult to not be super close to this topic. So I hope that you all can see evidence of that as the candles come through. I also just wanted this to be a time where we can honor those who are struggling with suicide and those of us who are compassionately and bravely stepping into those struggles to try to support the people that are going through this. Okay. And on that note, trying to destigmatize this subject and go over some myths versus facts. There is a myth, I feel like, just in the community. Suicide is always linked to mental illness, right? Like that's, something that would never happen to me. That's something that happens. People who are crazy, all of these kinds of really stigmatizing language. Suicide is actually not directly linked to mental illness, at least not all the time. Most who have died by suicide had a diagnosable mental health condition, but suicide is also triggered by severe stress, life events, crises. So it's important to make this separation and not have suicide be about mental illness. It's actually shown to be much more effective to treat suicide versus treating depression, right? If someone is suicidal, you're focusing on evidence-based interventions for suicidality, not on making the depression better, if that makes sense. So I know there's overlap between those two things, but there is that careful distinction of like, we're really going to focus on the suicidality and work on quality of life, which we'll talk more about later. Research actually indicates that about 10% of Americans have had suicidal thoughts at some point in their life. I would imagine that that number is probably quite a bit higher because this data is dependent on disclosure, and there's so much stigma and pressures in disclosing suicidality that a lot of people don't do it. Another myth is talking about suicide will make things worse and may even encourage suicidal behavior. That has shown to be false as well. Talking about suicide helps reduce stigma, helps reduce shame, saves lives. Many who talk about their suicidality, their experience, report feeling better after sharing those thoughts, or at least report that it didn't make things any worse. I'm going to breeze through statistics. I don't need to explain to you guys what a big deal this is. The numbers have pretty much continued to climb throughout the years. It's pretty staggering data. So I'm also going to make a quick note about suicide statistics in general. A lot of the data that we pull is from the CDC. So they are pulling data from the National Violent Death Reporting System. And that's the only system in the country that takes information from different states and compiles it, puts it all together. Every state participates in this system and sends data, but it takes about 2 years for it actually to show up so we can use it and respond to it. So that is a big time lag time in a really important subject, that we need data on. We need to know what's happening. We need to know where it's happening. We need to know who it's happening with. But that data is 2 years behind. Sometimes it's even more in that 2 to 4 range.
Two things real quick.
So that also means that our leaders are making state level policy decisions, funding decisions with data that's 2 to 4. So I wanted to tell you a little side story, and I am going to give you this person's information in one of the resource slides. There is a woman named Kimberly Rep. She is a supervisor in the medical examiner's office in Washington County, which is in Oregon. So she saw this problem occurring with out-of-date data, and she decided to take her own data within her county. She was already having to do it to report the data to the National Violent Death Reporting System. The medical examiner's office is required to do that. So she already had all these statistics. I think she might have made a different form or something so they could keep their own data for their own individual county. And she worked with community agencies to develop interventions.
Alessa, you just got muted.
Thank you.
Thank you.
I don't know how long I was muted.
Just a few seconds.
Okay. So, to back up a few seconds. So this woman, Kimberly Rep, was compiling data from her own county, and she was able to pull these stats in 1 to 2 days. So she had all this information, and it was coming in real time. So she started working with community agencies to develop real-time interventions based on this data. And what she was able to do was absolutely incredible. She would, just like a couple of examples, there was data coming in that a particular hotel in the county was a place people were selecting for suicide. So there were deaths by suicide, several of them in 1 month. So she went in with mental health professionals and trained the motel staff, right? The people who are checking in their clients, the housekeeping staff, anyone that was around in that motel. They were trained in QPR, question, persuade, and refer. So, which is a suicide prevention strategy. And there, I want to say that there were about 4 or 5 deaths there in 1 month. And a year and a half later, after implementing this program within the motel, they had a total of 1 death in a year and a half versus 4 or 5 in 1 month. So she was doing a lot of really, really targeted, really creative interventions, and she reduced suicides in Washington County. Are you guys ready for this? By 40%. So as the national numbers and state numbers are just like climbing, she reduced by 40%. And I think that was in, I want to say it was like 1 to 2 years. I'm actually going to give you the link to watch her presentation because I found it online. I found the presentation that I got to see. So I'll share that with you all and you can have access. There are a lot of other states and counties that are adopting her strategies. So hopefully that will continue to spread because obviously those are awesome numbers. Because the numbers that are on this slide are not good. Over 49,000 Americans died by suicide in 2022. So this is most recent data. One death every 11 minutes here. 13.2 million seriously thought about suicide. And that's about 4% of the population. So when I gave you that 10% number, that was suicidal ideations, kind of contemplation. This is serious ideation. Like I'm thinking about planning, I may have intention. And 1.6 million attempted suicide. Overall, suicide rates increased 37% between 2020 and 2018. Then the numbers went down by about 5% from 2018 to 2020. And by 2021, we were almost back up to where it was before the numbers started to drop. So this, for some reason, this data was a bit older. I don't know if that has anything to do with that 2 to 4 year thing, but this is, I think, older than 2022. This might be 2020. But I did want to point out that statistic that 10% of Americans have thought about suicide. And this is definitely more grounds to talk about suicide with our clients, right? Even the ones that are not just bringing this information to us. We're going to ask the questions and validate and normalize emotions that come with this. So these are a graph on suicide methods. I want to highlight here that 55% of suicides are completed through use of firearms. This is really hugely important as we go through lethal means counseling. There is a lot of research and evidence related to firearms and the relationship with suicide. So we will continue to talk through this in the presentation, but I did want to give you that data. The firearms account for over half of all suicide deaths. So this is our Virginia data. And a few things I wanted to pull from here. In our state, suicide is the 10th leading cause of death. 58% of communities did not have enough mental health providers to serve residents in 2023. Over 4 times as many people died by suicide than in alcohol-related motor vehicle accidents, just to give that perspective. And 60%, instead of 55%, 60% of Virginia suicides were completed through use of a firearm. %50 of people who die by suicide see their primary care doctor in the month before their death. This is another way that we can be intervening. This is probably a few years ago now. I was at one of my appointments with my primary care, a physical appointment or something. And they screened me for suicide in the beginning. And I'm sure the nurse thought I was absolutely out of my mind because I got excited about it. And I thanked her for doing that because I know this data point, right? That there is opportunity to catch this, by medical professionals, because people are seeing their doctor in the month before they die. So, is it going to completely solve the problem? No, absolutely not. Is it an opportunity to help? Absolutely, yes. So, Risk factors. Sense of hopelessness, history of physical and sexual abuse, a general trauma history, relationship loss is a huge one. Of course, we've got mental health disorders that can be more correlated with suicide. Family history of suicide, prior suicide attempts, access to lethal means is a huge one. Impulsivity, tendency towards impulsivity, insomnia, self-injury. And self-injury can go either way, but sometimes I feel like there is the notion that, oh, that's attention-seeking behavior, or that there's no way that could have any kind of intention related to suicide around it. But we need to ask questions around self-injury to see what the person's intent is. Sometimes it is that, relief of numbness, desire to feel pain. And sometimes it is more of a buildup to suicide. Especially when we're at hospitalization level related to self-injury, we need to be checking in on those things. So more risk factors. After a patient leaves the hospital, if they have a psychiatric hospitalization, they are at risk following discharge. Starting and stopping certain medications, social isolation, loneliness, limited support system, even just living alone puts you at a higher risk. Perceived burdensomeness. Those of us who have worked with suicide, I know we've seen that come up, right? Like the person just feels like they're a burden. They're a burden to their family. They're a burden to their friend. They need too much. Unwillingness to accept help when that's coupled with that burdensomeness, that can be really dangerous. Unemployment or employment problems, legal problems, financial problems, personal loss, military personnel and veteran status, LGBTQ plus community. Clinicians are at higher risk for suicide. Medical professionals. Suicide contagion is a risk factor too. So even celebrity deaths can put people at higher risk for there to be kind of a chain reaction of suicides. Social trauma and bullying, chronic disease, chronic pain, disability, lack of access to behavioral health care. So moving from risk factors to warning signs, there are tons of risk factors. There are tons of warning signs, and none of these are allowing us to predict suicidality 100%. So we're collecting these things that are steering us in the right direction, but obviously from the numbers, we're definitely not there yet. So we're talking about these things, and you're also listening for the more underlying indicators that something might be wrong, right? Those like subtle changes in mood or behaviors, or a client coming to you and just looking depleted, right? Saying that I'm just exhausted. I'm so tired. I'm struggling to care, right? It's not worth it anymore. Withdrawing from friends, family, and community, giving away important items, changes in appetite, eating, mood, behavior, cutting back on activities, previous interests, increased drug or alcohol use, reckless behavior, difficulty at school, failing grades, bullying, conflict with friends, parents, making comments about being hopeless, helpless, or worthless, increased guilt and shame, feeling like a burden to others, and of course, talking about death or expressing that they want to die. So suicide prevention, I have, that word in the title of my presentation that is often a word that we associate with suicide because, of course, we want to prevent suicides. There's a problem focusing purely on preventing death, right? The just don't kill yourself, right, is not the only thing that we're focusing on. We're doing that in the crisis moments. But that's not the message, even in those moments, that we want to be sending to our clients, because the lack of hope, of quality of life that they're experiencing in a moment of suicidality is so strong and so awful, right? So an approach of just don't die is not going to be helpful for the people that we're working with, if that makes sense. We're going to instead move our client through this point in their lives, right? Support them in staying safe, and also continue to focus on the suicidality and improve their quality of life, increase their hopefulness, their engagement, the meaning that they have in their life. And we're going to respond compassionately with validation in that process. Also, just in terms of, stepping in as early as possible, please include discussions about suicide in your informed consent. Provide clients with crisis resources, even if they're not expressing suicidality or a history of suicidality. And say a little bit about lethal means counseling, which we'll go into more detail about in a little bit. The goal is really just to open up dialogue throughout treatment about this subject, because even if the client is not directly struggling with suicide themselves, chances are they are exposed to someone, living with someone, friends with someone who is, and we want to open up the conversation. For us as clinicians, I want to focus on response versus reaction to suicidal disclosure. So I want everyone to think about, maybe if you've been working with suicidality for a while, think back to in the beginning when you first started having clients who were suicidal. How did you feel as the provider? What kind of thoughts were going through your head? Was it more of a fear response, an anxiety response, maybe a focus on liability that comes up a ton for providers? That kind of provider anxiety and fear can cause avoidance. Sometimes it can even turn into annoyance, right? If you have a very chronically suicidal client. The doorknob disclosures, right? Somebody telling you about suicidal thinking, like right at the very end. I want to normalize and validate that it is so hard to step into these spaces, and there's so many challenges. And of course, we care about the people that we're working with. Being literally faced with life and death situations in our work is stressful and hard and can cause some really strong feelings. So I want to put that out there as validation for all of you who are in this. And then hopefully move into an approach that can take away some of that anxiety, fear, annoyance, avoidance kind of stuff that might be happening. So those of us who have had some DBT training, we're going to talk about wise mind in the context of response versus reaction. So when we are having a very strong emotional response, we are pulled into what DBT calls our emotion mind, right? Where everything can be like on fire, and we're very much into our feelings and we don't have access to reason and logic, some of those prefrontal cortex functions. So we're going to do things to lessen the emotional reactivity to a level that still allows compassion and empathy. And we're going to balance it with our reason mind to create a wise mind approach, right? Like that's the wise mind Venn diagram, the emotion mind coming together with the reason mind. And in the middle, in that center section, you get wise mind. So a balance of compassion, empathy, validation, right? Like trying to be in that place of understanding, and also rational, logical thought in order to support this person in being safe and support their care, beyond that moment as well. That's where I want us to get to in our response to clients. So whatever works for you to balance those responses. Maybe you're even too much in logic and reason mind, right? That's harder for you to access the emotional piece. So doing what you need to do as providers in the field and to achieve that balance so that you can make the best decisions and best support your clients, because that's what we do in that wise mind state. So another thing I want to reiterate is just language. I feel like we've already done some really good work in getting rid of some damaging language, like the term committed suicide, right? Associating suicide with, like criminal behavior. That is very harmful for people who are struggling with that. It's very harmful for families and friends of people who they've lost to suicide. So if we can change our language to lost their life to suicide, died by suicide, that's where we want to focus versus committed. Also, terms like attention-seeking behaviors, let's try to take those out of suicidal conversations. That goes into that category of emotional invalidation, right? Like this isn't that bad. You're just trying to get attention. And it also takes us out of a place where we can make the best decisions for that client, because how are we really going to know the root cause anyway? And we might be making a decision that is putting the client in an unsafe situation. So if we can kind of reframe that for ourselves, that's important. The suicidal gestures for secondary gain, kind of along those lines of attention-seeking behaviors, those are just problematic descriptions. Stigmatizing language, counterproductive associations, we're going to work on getting rid of those, destigmatizing, increasing our compassion, died by suicide, lost their life to suicide, terms like that. Let's see how far. Oh, I'm actually doing okay in terms of time. Okay. So next is just a little more background on this response to a client's initial disclosures of suicide. So let's say, this is the first time you're going through this with this particular client, or you have a new intake, you're just meeting this person and they disclose suicidal thoughts. So these are just things to keep in mind for that situation. Suicidal thoughts and attempts are signs of intense emotional pain. Emotional pain is a human experience, but especially in those periods of suicidality, they're feeling very alone in that human experience. Suicidal thoughts and attempts are an effort to end that pain, suffering, loneliness, rejection, right? It's oftentimes that's how people who are suicidal describe things, right? Like, I don't necessarily want to die, but I want this other stuff to stop happening. And I don't know how to get it to stop happening other than this option of suicide. We want to reinforce to our clients that they're not alone in their emotional experiences, and there's people who do want to help. So it's a careful balance in doing this with validation, right? Because we also don't want to invalidate their feelings, right? If they're feeling like everybody's against them and no one cares, it's not a yes, we do, yes, we care, right? It's not that kind of interaction, because that creates a combative interaction with the client, which is going to further increase stress, invalidation, and not be helpful for the situation that you're in. But if you can start to pull just little bits of evidence, right, that this might not be true, that there is no one in the entire world that cares about you, and start to, put that into our conversations. Just reinforce that there are people that do want to help. There are other options. Validate the unbearable feelings that have led them to this place. I know that this is a really uncomfortable thing for a lot of people to do. Like, I'm using validation in a suicidal situation. So validation is not agreeing with the suicidal thought. It's not supporting suicide. It's validating the just enormous awfulness of what they're going through that brought them to that point of thinking that ending their life is an option or the only option to what they're going through. You can even normalize that response in the unique context of what that client is going through. So, you just got divorced, a few months ago, and now you've lost your house, right? Like, it feels like you have absolutely nothing. Of course, you would be in the place of extremes right now. All these extreme things have happened to you, so it would sound something like that. We're going to try not to pathologize suicide, fuel shame and stigma around suicide, emphasize the role and the importance of emotional self-management skills, or like emotional fluency. Vulnerability and emotional pain is a part of human experience. People who are suicidal don't have access to that, right? Like, it's this, like we just talked about, it's this sense of aloneness. Like, nobody else is experiencing this. Nobody else cares that I'm experiencing this. So if we can, and this is moving towards like quality of life stuff, if we can start to compare the emotional pain to maybe like physical pain, right? When we are trying to, as simple as just like stay on a workout routine, right? Like, there is pain, there is discomfort in building up muscle tone, right? Like doing cardio. If we can start to equate that kind of physical stamina with also building emotional stamina in order to endure these stressors and still have access to those parts of our brain that allow us to problem solve and realize that there's other options. Sometimes that can be helpful, a helpful comparison, right? It feels like this emotional distress is like just this outer space experience when actually it's very human, and but there's all this stigma around it. There's not all this stigma around physical pain, going through physical therapy after an injury, right? But with suicide, with mental health crises, unfortunately, there's still stigma around that, and it makes it a lot harder for people to work towards that emotional regulation, that idea of this is a human experience. So that's part of our job, is to help them get there. We're going to go into suicide assessment strategies. There are lots of different strategies or assessments, that exist. And again, please go by, what your agency policy is on assessment. Even if you're doing a standard assessment, there should still be a conversation. So make sure that you're including these things in your assessment with someone who may be suicidal. Risk factors that we identified before, also protective factors, things that support them in not moving towards suicide. And I will list some of those on one of the next slides. History of suicidal ideation or attempts. Obviously, current suicidal ideation, we want to be very directly asking about that. How specific, lethal, available is their plan for suicide, if a plan exists. So we want to be looking at all of those things, like figuring out what their plan is, and then being able to assess, especially lethality and availability. And also just their proximity to social support, right? Like how physically far away are they from somebody? Is there someone who is going to answer the phone if they call? Is there someone who checks in on them? Do they live with somebody? Client's mood, level of agitation, self-control, hopefulness, any changes in behavior if you've been working with the client for a while. Suicidal intention is important, right? If that plan is there, do I have an intention to follow through? Reasons for living, reasons to keep going, reasons to stay healthy. And safety planning, which we'll go through some steps so you guys can have kind of an outline of a good solid safety plan. And then consultation is always a good idea. Suicide can be a life and death situation. Suicidal ideations can be a life and death situation. So when someone's expressing this to you, it's always good to have another set of eyes and ears on the situation. This is probably the most widely used suicide assessment, the Columbia Suicide Severity Rating Scale. No mental health training is needed to do this assessment. They could be used in multiple settings, and you don't need permission to use this. This is very easy just to find online. You can also find trainings in using the Columbia. So this is one of those slides that I'm going to breeze through a bit because you have the questions, okay? So the questions are the what to ask and how to phrase it, right? As you perform these verbal interviews and assessments, make sure you're reflecting back to the client to ensure you're understanding them correctly. Make sure you're using the validation, normalization of feelings, and make sure that you are asking about suicidality very directly. We're not going to beat around the bush. We're not going to use more fluffy terms, right? We're going to ask, like, have you been thinking about killing yourself? Or we're going to use gentle assumption, right? And ask, when is the last time you thought about killing yourself? So normalizing that this is something that many human beings go through, and phrasing the question that way. So that way the client can say, like, I've never thought about that. What are you talking about? Right? Or it leaves it more open if the client is on the fence about whether or not to say anything. They're like, oh, I have an opening, right? They're asking me about the last time. So this is okay to say out loud. Okay. More points to explore. This is from a suicide training that I did maybe like 2 years ago. And I thought what this person had to say was really, really interesting. He works with almost all of his clients are suicidal. He works a lot with the military, and he is noticing in all his years of work that suicidality almost always falls into one of 3 categories. So this is like the cause and the experience for people. Unlovability, the belief that I'm damaged, I'm worthless, I'm a failure. Unbearability, feelings are unmanageable, it's too overwhelming, it's too much, I cannot bear this. Unsolvability, I don't have any options. The problems that I'm having now can't be solved. So if we are discussing these experiences with the client throughout treatment, even outside of periods of suicidality, we'll get a gauge of how well they're doing. So those are important topics to check in about. And it also gives us 3 points where we can highlight those little pieces of evidence against those things, right? If someone, if their neighbor stopped by, to, I don't know, give them some coffee, right? They went and got coffee and, brought them a drink, right? That's evidence against unlovability, right? So you can start to touch on those things. So explore the part of them that wants to die and the part of them that wants to live. That can be a very helpful thing to sift through as well, kind of that internal family systems work. So there's something that's kept them alive to the point that they're sitting and having a conversation with you about this. They're in your office. There's something that has gotten them to that point. So there's a part of them that is fighting to live. And there's obviously a part of them that also wants to die. These suicidal thoughts are present. So let's talk about both of those parts and focus on the part that does want to live and build some things from there. Okay. And I think that is a good stopping point for a break. So it's 11 o'clock. Let's take 10 minutes.
Okay.
Okay.
All right, everybody, please be back at 11:10. Thank you.
Okay.
Awesome. So now we're going to move in from risk factors, warning signs, assessment, questions to ask, to safety planning. And also, woven through the whole presentation is that compassionate response. So the same is going to be true in safety planning. And that brings me to my first point of a safety plan is a plan that you create with the client. If there is suicidal ideation present, self-harm ideation present, and it's at a level, right, after assessment where they're not going to need a higher level of care. They don't need to go to the hospital, but they still are going to need some tools, some resources, some crisis resources in case things do escalate and get worse, so that they have a plan if the symptoms don't improve. A safety plan is different from a safety contract. Safety contracts are done kind of to clients, right? It's a contract that the client signs where they're saying, I promise to not hurt myself, kill myself, attempt to kill myself until the next time I see you, and then they sign their name to it. So those are not helpful, not effective, can be damaging, and they in no way, shape, or form protect against liability. That safety contracts probably came from that kind of fear response of providers. And we do not want to be responding out of that high level fear state with anything. And so please don't do safety contracts. Safety planning is appropriate. The patient must be able to participate in their own safety planning. That means that if they refuse or they're psychotic, maybe in a psychotic state, you're not going to be able to do that for them. They need to be able to participate with you. So there's going to need to be another plan, probably with a support person, if a safety plan isn't able to be made, because the patient has to be able to participate in that. And even if you are doing a safety plan, it is definitely best practice to involve other supports in the client's safety plan. So hopefully someone that they live with or someone that they have close proximity to, a family member. With kids, I work with a lot of kids and teens who are struggling with suicidality. So obviously their parent or guardian is brought into the discussion and included in the safety plan, because there's things that the support person is going to have to take action on too, in the components of the safety plan. So these are the categories that make up a safety plan. And I got this one from the Brown Stanley safety plan template, and I've included the site there. But just Googling that will bring it up. It's on a few different websites. They include these categories. I might have changed the wording on them a little bit, because these are the categories from my own safety plan. The first one is early warning signs that a crisis might be beginning or that things might be getting worse. So these are thoughts, images, feelings that the client is identifying that indicate things might be worsening. I always ask them to also include an observable warning sign that somebody else might be able to see in them, like, the change in behavior, more isolation, so that another person might know that things were getting worse or things might be getting worse. So I try really hard to do an observable one as well. Coping and distraction skills is the next category. So if they feel things starting to get worse, or if they're just, trying to regulate themselves in general, they need a list of coping and distraction skills. When we are too much in emotion mind, we can't access the brain power that it takes to identify our coping skills, to think of something that might distract us. So we're writing everything down and we're creating that plan with supportive people around them. So they list things that help. I really, really emphasize the power of distraction when I'm safety planning with clients. I feel like distraction gets a bad rap in the mental health field, right? We want to, our clients to be able to sit with the feelings and, distress tolerance and all of those things. And distress tolerance actually sometimes involves distraction too. But distraction is going to provide time for the intensity of those suicidal thoughts or self-harm thoughts to calm down. We can't hold high levels of suicidality or high emotional states forever. It just like our bodies are not physically capable of that. So if we can create some time and distance, we're going to be able to keep our clients safer. And distraction is a way to do that, to kind of give your brain a break and give it time for those things to calm down. So, safe people and places that provide distraction. So that's different than the skills and activities we've listed in the previous session. These are, friends, sometimes family members, places that they feel safe or that are like, visually interesting. And please make sure as the provider, like helping to create the safety plan, that the places that they're listing in there are safe. Like I feel safe in my room, so I'm going to lock myself in the room for as long as I want and nobody can come in, right? Like if a kid is telling you that, it's like, okay, well, let's talk about maybe another way to have your safe place, right? And feel like you're getting that time and that space and that separation and still staying safe. There's a compromise somewhere in there. So people whom I can ask for help. So these are people that you can reach out to in a crisis. With kids, make sure these are appropriate adults that they could talk to. I also, with kids, try to include adults in each of the environments that they're going to be in for long periods of time, right? Like if they live in two different houses, like who's going to be your person in this house, who's going to be your person in this house, or who are you going to call when you're in each one of those places? And then at school, is there a teacher? Can you go to the guidance office? Like, what do you feel most comfortable doing? And then professionals or agencies I can contact during a crisis. These are your crisis resources. And I have a slide on that. So you all have some emergency resources listed out. Environmental safety is the next one. And this is also where you would put in lethal means counseling, which I also have a slide on. So we'll come back to that. But in the safety plan, you want the client and the support person to be agreeing on ways to restrict access to dangerous items, particularly items that could be lethal. So we'll talk about that. Last section, I always end with this one, are reasons for living. So what is keeping you going? Why do you want to stay alive? Why do you want to stay healthy? What's that part of you, right? That's fighting and wanting those things. And again, taking that stance of validation. I don't care how silly the reasons for living are. So I've worked with a client who the only reason for living she could think of was being able to hear new music from this K-pop band. I'm going to put it on her safety plan. Like that's, she had tons of support around her at home, at school, with friends, but it was the K-pop band. So, okay, that's what we're going to go with. And we're going to try to talk about, maybe some other options to add on there, but if she doesn't want to, I'm not putting them on there. So very much like a empowering thing, right? Like the client knows deep in there, right, what's going to actually motivate them to stay safe and to get better. So working on validation and compassion in all of these areas as well. Crisis resources. I think we probably all know about these, but I wanted to just put them all on one page. So Suicide and Crisis Lifeline, Crisis Text Line. Oh, and the Youth Line. This is a really awesome one for young people because it is a teen to teen, like peer support line. So when they call in, it has to be during certain hours, but when they call in, they actually get to talk to another teen who has gone through some kind of mental health struggles themselves and is trained to facilitate these calls. There is a lot of growing evidence of peer support, which I will be talking about more in the second part of this presentation. So I really like that one for teens. They tend to feel a lot more comfortable calling into a line like that than they would maybe the Suicide Lifeline. I also, if you guys want to make a note of this, I also let clients know who are really hesitant to use crisis lines that only about 3% of callers, I think this is data from 988, the Crisis Lifeline, only about 3% of callers need intervention from the Lifeline. So, police being called, some kind of like disruptive intervention like that only happens about 3% of the time for people that call in. So a lot of clients have the notion that they're going to pick up the phone and say suicide and they're going to have people kicking down their door to come get them. And that's not the case. So I try to put that framework on it. The Trevor Project is another resource for young people in the LGBTQ plus community, which is a high-risk group for suicide. So that's a very important resource to give out. Veterans Crisis Line, and then, of course, inpatient hospitals in the area, your local emergency room, or calling 911. I'm not sure. The last time I checked on this, we were really close to every locality in Virginia having access to text 911. But double check on that for your area. You can also tell your clients that. I have had somebody do that. She literally was just in such a state she could not think of anything else to do. And this was years and years and years ago. I didn't even know you could text 911, and she just tried it, and somebody answered her, and came and got her. So that's a resource as well. But check on the text thing if you're to share that with your clients, because that's often a good option too. It's harder sometimes for people to make phone calls than it is to chat or to text. Okay, so finally we're getting to lethal means counseling. Firearms are the most lethal and most common method of suicide in the US. More people who die by suicide use a gun than all other methods combined. Suicide attempts with a firearm are almost always fatal, which is a big part of the problem. every US study that has examined this relationship between firearms and suicide has found that access to firearms is a risk factor. So like we're sure about that one. There's lots of other question marks in this area, but we know that these things are linked, suicides and firearms. It doesn't mean that firearm owners are more suicidal than non-firearm owners, but it does mean that the attempts are more likely to be fatal, and that having a firearm in your home gives you very quick access to make an impulsive decision. So the role of impulse is huge in suicide and suicide attempts. They're often made with little planning during a short-term period of crisis. So if these highly lethal means are made less available, or there is strategic inconvenience in getting access to them, that keeps people safer. The more that we can postpone the time between I have the urge and intention to kill myself and getting access to actually being able to do that, getting access to something that would allow you to do that, the more time that we can put in there, the safer people are going to be. So that is means restriction and lethal means counseling. So we're sharing this with clients. So strategic inconvenience, let's talk about that. Things that can be more fatal: firearms, medications, knives, and bridges, right? These are major things. So we're helping the client to create strategic inconvenience. And it doesn't have to be, you are confined to one place in your house and you can't move and you can't touch anything, right? That doesn't have to be what it is. That isn't what it is. So with firearms, there's obviously all kinds of storage options. Ideally, we want the firearms out of the house during periods of suicidality. When suicidal ideation is present, like, let's go ahead and just totally remove that method so that the person doesn't have access when they're in this state. Doesn't mean they have to stay out of the house forever, but if we can temporarily do that, that's going to be very helpful, likely going to be very helpful. So they can store the firearm with a friend, out of the home. There's also a lot of the gun ranges will store it for you. Sometimes there's a fee. And sometimes you can even look in your area with just like community resources on alternative storage options for firearms that are temporary. If they are not willing to remove the firearm from the home, trigger locks, gun safe, storing ammunition separately, that's that strategic inconvenience, spacing out the time that everything could get put together, right, to have full access to lethal means. With medications, if there's a parent or support person who can just take over providing the medications, that's ideal. If not, breaking up medications into non-lethal doses and separating them, so there's actual like physical movement that has to occur in order to like collect enough medication to do harm to yourself. Knives, it's been shown that limiting access to symbolic ones is helpful for safety. So somebody has like, a pocket knife that, their grandfather gave them or something, or it has some kind of knives stored in their room, like in their close vicinity. Let's get those out of there and just, strategic inconvenience, right? Increase the time. Sometimes if knives are like being thought about or have been used in the past, I do ask parents of kiddos to lock the knives up temporarily. And I tell them, I know it's super annoying. You use knives every day, but like just to temporarily, right, during this period where things are not safe, you know, the thoughts that your child is having are not safe. Let's remove the means. Bridges, practicing emotional regulation before you go over the bridge, reviewing reasons for living, that kind of stuff. There is a really great resource out of Harvard. The website is here. They do a wonderful job of explaining lethal means counseling to clinicians, right? Like things that you can say to your clients, verbiage you can use. There's resources for clients, community resources, families, you know, concerned loved ones, colleges and universities. And they also have a section on firearms owners, right? And how to specifically speak with them about risk, because we all know that ownership of firearms is a hot button topic right now. There's a lot of political things involved in it. And the clinician section will give you great verbiage for that and kind of allow you to approach that in a very compassionate and validating way, right? That still really encourages safety. So I love that resource. Protective factors. So reasons for living, like we talked about in that last section of the safety plan, life satisfaction, social, familial support, sense of belongingness, absence of burdensomeness, right? Having children in the home, being pregnant, spirituality, religious service attendance or beliefs, connection to pets. Don't underestimate the power of that. Healthy coping skills, problem-solving skills, a supportive school environment for kids really, really helps. Frustration tolerance, having that skill set, limited access to lethal means, and strong therapeutic rapport if you are in a therapeutic relationship with them. So assessing need for higher levels of care, hospitalization. Again, always follow your guidelines for your agency, your board, best practice. Always that comes first. Generally speaking, the more detailed the suicidal ideation, suicidal plan, and means, the greater the suicidal risk. If those three things are present, I am sending the person to the hospital. Suicidal ideation present, suicidal plan, specific plan present, and intention present, and means. That's a high risk situation. So make sure that we're facilitating the conversation with the parent, if it is a teen or child, a minor, or support person to help that transition to a higher level of care. And when possible, facilitate a soft handoff to the ER for assessment or the acute hospital, including assessing safety and how that client is going to be transported, right? So you're not going to send an adult client to the hospital by themselves if their plan is to drive their car off of a bridge, right? I know that's a very extreme one, but we're really going to think about keeping the person as safe as possible and involving other people that will be able to support this process. We're going to let the hospital know that this patient is coming with an appropriate release, of course. But those are the best practice kinds of things in facilitating transition to a higher level of care. Documentation is, of course, super important. And I will once again say, please act within the policy of your agency. In general, when you are working with suicidal clients, you want documentation that shows you conducted the risk assessment thoroughly. You obtained adequate historical information related to suicidality, self-harm, hospitalization, suicide attempts. You obtained records regarding previous therapy. That is a best practice kind of thing. You asked directly about suicidal thoughts and impulses. Document that. Consulted with one or more professionals, also a best practice thing. Discuss limits of confidentiality. So because suicidality is a safety concern, there are going to be times where you might bring in somebody that the client doesn't want to be there. I talk about this all the time with my kids and teens when I have to bring in their parent. There is understandably a lot of resistance to that and a lot of fear associated in that. So I'm validating, and also still following through on involving other people in their safety. Developing the collaborative safety plan, make sure you're writing about that you provided safety and crisis resources and discussed restriction of access to firearms or other lethal means. Okay, in summary, responding to suicidality, honor and validate, compassionate response, be direct. We are not beating around the bush when we are assessing for suicide. Actively listen without judgment, use reflection, seek out professional consult if you are able, determine, plan, and provide resources. So whether that is the safety planning process, whether the client needs to go to the hospital, you are determining that and communicating that. Incorporate support persons into the safety planning process with the client present. I have had a few situations where the client refuses to be there, but I really don't like that. I do not like talking about the client without the client there. Recognize courage and strengths involved in this process. It is a tremendous act of courage to step forward and disclose suicidality. So make sure that you are acknowledging that and sitting with that, recognizing the strength in doing that. Document, and follow up with the client. So even if they are hospitalized, checking in to see about coordination of care, discharge planning, right? Are they going to come back to you if you were seeing them in an outpatient setting? What's going to happen? What's the plan there as well? Okay. So preventing suicide, just kind of a summary about this prevention, also in the context of not just preventing the person dying, right? Preventing the buildup of things that leads to suicidality, and supporting the emotional regulation and stamina, right, to endure stressors so that it doesn't get to suicidality. So we do that by having conversations about suicide, keeping that open dialogue, updating or creating an organizational protocol for response to suicidal clients and response to completed suicides within your organization. So how are you going to respond if a client does die by suicide? how is the family? How are you going to respond to the family? What's going to happen after that? Protocols need to be in place for that as well. Compassion. Reduce access to lethal means among at-risk persons. Oh, yes, I forgot to talk about this. So prescription medication disposal, you can find authorized collectors in your area. Sometimes we have medications that we don't need anymore, that might be dangerous, that might just be taking up space, right? So there are places you can go to have someone take care of disposal for you, safe disposal. And then firearms collection, destruction, or storage is also an option. Ease transitions for children and teens with mental health conditions and other life challenges. Strengthen access to and delivery of care and support, like I said, family and friends after a suicide loss. Okay, I'm going to go super quickly through these. I want to talk about empowerment in terms of peer support on a few different levels. So there are now so many organizations that will help you as a non-mental health professional, right? If I am a middle schooler, I can go onto these sites and get support, education, resources on helping one of my friends who might be struggling with suicidality. I get that question a ton in my practice. I don't know if you guys do as well. It is my clients have been incredibly distressed by their friends, struggling with life crises and suicidal thoughts. And they want to be able to do something that helps, because seeing that level of distress puts them in a helpless situation, which is a risk factor for them. So if we can empower the people that we work with, the families that we work with, the other people, our communities, really, to be advocates, right? To know these things that they can do to help, that is going to improve quality of life for people. So these are a few of those sites. Save.org, Step Up. Step Up is actually like more all-encompassing. It goes beyond suicide. Evidence-based pro-social behavior and bystander intervention program. Very cool. Take 5 to Save Lives, the Action Alliance, stopbullying.gov. So training and resources. A lot of these anti-bullying agencies will actually come into your school or organization and do trainings for you, which is very helpful. I put this one on here because a lot of people don't know that concerned friends and family can actually call the Suicide and Crisis Lifeline as well to get resources to help people that they care about. So that's another way to empower. Peer support. So we talked about just ways, community resources, ways that we can empower people to help each other. There is also a lot of very specific peer-to-peer support for people struggling with suicidality. So there are groups where, and they are peer-led. So there is not a counselor or someone in a higher up position that is facilitating these groups. They are facilitated by the people who are in that experience. And I think as mental health professionals, we can get a little scared of that, right? Like, we're just going to send somebody into like a pool of suicidality, right? Like with other people who are struggling with the exact same thing. But it's actually shown to be really, really helpful and a much safer space for our clients, because they don't have to worry that someone is going to preemptively call the police or send them to the hospital or take control over an aspect of their lives that they don't want someone to take control over. So there's some growing research on it. I would encourage you all to just look into it. NAMI actually offers peer-led support groups for clients and their families, so that's a good option. There are also peer respite services. I don't know of any that exist in Virginia, but kind of a cool concept. Hospitalization can be incredibly traumatizing. So a peer respite program is an option, an alternative for hospitalization or a step down from hospitalization. And that's another peer support type idea. And it's neat. If you want to read more into it, the website is right there because I'm running out of time. I wanted to tell you guys more about that, but community engagement resources. So the American Foundation for Suicide Prevention offers several programs that take into account cultural aspects of suicide. Someone asked about gender and suicide, a difference in how people of different genders complete suicide. So yes, there is a difference. More males die by suicide. The stat is something like, 50% of our population is male, but 80% of those who die by suicide are male. There's also a much higher rate for the LGBTQ plus community. The American Foundation for Suicide Prevention takes into account cultural aspects and offers trainings specific to that. So there's faith-based trainings so that faith leaders can help in their communities. The workplace settings for seniors, Latinx and Hispanic communities. So they're just doing a really good job. You guys have that. Also out of the darkness walks, which I think we're probably all familiar with, but that can just be a great way to get involved and engaged in our community. Resources for clinicians. Just listed a couple of these. I'm trying to look and see if there's anything specific I wanted to say. There's so many places where we can get education, training, resources, advocacy, support, lethal means counseling. So this is a list of sites for us as providers. And then I also want to highlight emotion-focused support and validation. There's a technique called emotion coaching that came out of emotion-focused family therapy. And if you go to this Mental Health Foundation's website, there's actually a video there that shows you how to validate someone in a period of suicidality. And I feel like it just does a really great job. It offers a lot of resources for both clinicians and parents. So I've also used this with the families that I work with. And this is the presentation that I referenced in the beginning by Kimberly Rep, who works in the medical examiner's office in Washington County in Oregon. So her presentation is, if you want to save lives, start with the dead, because she is collecting data on people who have died by suicide and creating interventions based on that. So I would highly recommend, and if anybody wants to keep her initiative going, I think that would be really cool. So that's for you guys. Okay, so we flew through. We just covered a ton. And I wanted to take a brief pause because suicide is such a heavy subject, and it can also be triggering, right? We saw how many candles were sent in the chat, and our closeness, right, to the issue of suicidality. So I want us to just take a moment to like kind of come back to earth. Mindfulness is a great way to do that. So I'd encourage you to pick one of the five senses, or maybe even a couple of them, and just like notice things around you that you can engage with related to the five senses. Maybe it's, being able to just like smell your coffee for a minute, or, feel your feet on the floor, like, touching a chair or a pillow, blanket, looking at a picture that you might have on your desk. But just taking a minute, you can absolutely turn off your camera, so that we can just kind of come back grounded, because we just did a lot of high intensity stuff. I would also love it, as we go into the question period, if you could type into the chat something that you can take with you from this presentation, and something that you can act on. So like, this is what I'm going to do in my practice. This is something that I'm going to do in my community. I'm going to focus on validation. I'm going to try to get into my wise mind when I'm responding to my clients. I'm going to watch the video, I'm going to go onto one of these websites, just something that you can commit to. And if you would type it into the chat if you feel comfortable, and or write it down somewhere where you have access to it. So in your notes app, on a sticky note, in a notebook, on your calendar, like wherever, you'll be able to see that, so that you can remember an intention from today, in going through like just a ton of information. So I'm going to leave it on a Robin Williams quote, which I feel like is appropriate. Everyone you meet is fighting a battle you know nothing about. Be kind, always. And I will take questions. I don't know, Karen, if you want to read them from the chat, or...
Sure, I can do that. I think you had answered the questions before. There was a question in the very beginning about why you thought 50% of people were going to their PCP ahead of time, if that was
That's right.
a somatic response or if there was another reason.
So I don't think it's specified in that study that I was reading, or that statistic, but I would imagine, we know that there's other risk factors, right? Like chronic pain, chronic disease, those kinds of things. So, regular checkups with your PCP, or maybe appointments for that, some kind of medical issue that's being followed up on. I would imagine it's that. I guess it could be somatic type complaints from just the, intense distress and emotional struggle. That is probably part of it as well, but it didn't specify.
There's just a lot of comments about the things people are going to be taking with them, educating loved ones, utilizing the resources, leaving ego out, be present, listen and validate. Somebody literally just also wrote, listen and validate.
Yes. Yay.
A repeated theme. I think you'd already cleared out the other question about 988 and what that is.
Yeah, that's a really important one. And you'll notice if you all start to Google and, kind of play around with some of these resources, you type in suicide or any related term into Google and 988 pops right up. So we're doing a lot of good things. I remember when that was not the case at all. There's also some data on, I think it was the American Foundation for Suicide Prevention. There was some data state by state on like what your state's school system is implementing in terms of suicide prevention and what's expected of mental health professionals. And that data was actually a little concerning. So if you want to look that up and see, what's going on in Virginia, that's a resource too.
One of the comments complimented you on your choice of background in your PowerPoint. It was soft and helped with such a heavy topic.
It's the art therapist in me. I can't use the standard templates. They just, yeah. So thank you for saying that.
Shifting negative thoughts in the moment, less on DSM related interventions. The slides will be available within the week because we'll be making up the certificates at the same time. Somebody pointed out that cultural safety concerns are going to differ from culture to culture. I don't know if you wanted to make any remarks on that.
Yes, I would use those resources to as you're working with clients from different cultural backgrounds, because yes, that's absolutely true. So I think again, the American Foundation for Suicidality had some good multicultural resources and ways to address those within certain communities, ways to approach things, verbiage to use. Yes, thank you for bringing that up. That's very important.
And then there was a question, is there a concise list of resources somewhere we could take with us during crisis calls?
Yes. Where's the best place? I would probably go to the Suicide Crisis and Lifeline website. Honestly, almost all of these sites, like the empowerment slides that I did with the different resources for the community, all of them tend to have like a PDF or some kind of handout or like flyer that lists emergency resources. I found it very helpful to compile things. Like I have a whole big list in my safety plan template that I will, kind of pick apart based on who's in front of me, like what kind of resources would be appropriate for that person, age-wise, culturally, all of those things. So I would encourage you to, as you're going through these resources, kind of compile your own based on who you're working with and what you can do there.
And I think this is a question, religious-based interventions for individuals who have strong faith, if you have any recommendations for that.
Yes. So that was, I think I would take you back to the faith-based training programs, Soul Shop. And Soul Shop for Black churches. So there's two different programs. And that was also from the American Foundation for Suicide Prevention. And it's important too that a protective factor and probably reasons for living that are going to come up in these faith-based conversations are beliefs around suicide, right? And what happens to us after we die. And if there is some kind of values conflict, right, associated with suicide.
You have a lot of thank yous, awesome presentation, great presentation. Be the reason someone feels seen, heard, and supported.